Good morning, everyone. So this is going to be a class on Hodgkin lymphoma and in mimickers. At the onset, I would like to thank Dr. Rajivan sir for inviting me to give this talk to the students. So what I've been made to understand is that this is a class aimed for first year and second year MD students. So it's going to be a very basic class showing you the cases, individual cases, the subtypes. Okay, so the initial few slides, how the presentation is going to go is that initial few slides, I'll be talking about Hodgkin lymphoma, the subtypes. There's a few basic slides. And then we will go on to each individual subtypes of Hodgkin lymphoma, where I will show slides. And then a few slides on mimickers of Hodgkin. Okay, so basically lymphoma can be divided into two types, a broad category, that is non-Hodgkin and Hodgkin lymphoma. So when we give a provisional diagnosis, the first thing a clinician is going to ask is that whether it's a Hodgkin or non-Hodgkin. Because the treatment of Hodgkin lymphoma is drastically different from that of a non-Hodgkin lymphoma. Non-Hodgkin lymphoma, if it's a B cell type, it's given by rituximab-based therapy, that is a R-CHOP. T cell is given by CHOP. Whereas Hodgkin lymphoma is usually treated with ABVD. So I'm not the best person to talk about the treatment, but I always feel that it is good to know how the lymphomas or each individual diagnosis that you render is going to have an implication on the treatment, how the patient is going to be managed. Because if you have that knowledge, you'll be more cautious in giving your diagnosis. You'll be more alert. Yeah. So just to know that Hodgkin lymphomas are treated differently from that of a non-Hodgkin lymphoma. Hence itself, it's important to diagnose Hodgkin separately from non-Hodgkin. Now, Hodgkin lymphoma is further classified into classic Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. So whenever a classification or subclassification is made, it is because it has an implication on the treatment or it has an implication on the prognosis of the disease. So nodular lymphocyte predominant Hodgkin lymphoma, I will be talking in detail in a few slides in the further presentation. It is quite different from that of a classic Hodgkin lymphoma. Okay, and the management wise also it's quite different. Nodular lymphocyte predominant Hodgkin lymphoma. Now the newer concept is that it is more like a B cell lymphoma and it is treated like a DLBCL based on rituximab based therapy like R-CHOP. So stage 1 has the option of just observing the patient or giving a radiotherapy alone. Whereas the stage 4 disease is given treated with the R-CHOP based regimen, at least in adults. So it is a very distinct entity from that of a classic Hodgkin lymphoma. That is why NLPHL is put in a separate category from rest of the Hodgkin lymphoma like nodular sclerosis, mixed cellularity, lymphocyte rich and lymphocyte depleted. Okay, so these are the further subclassification of a classic Hodgkin lymphoma. So 90% of the Hodgkin lymphoma is comprised by the classic Hodgkin lymphoma and NLPHL comprises around 10% of the Hodgkin lymphoma. Okay, now basically a small slide on about the etiology of the Hodgkin lymphoma. So basically, what is this lymphoma? It is basically a B cell lymphoma. The cells are said to be the Reed-Sternberg cell, which are supposed to be the malignant cells in the Hodgkin lymphoma. Is supposed to be a germinal center B cell origin. But the difference is that the lineage expression of this Reed-Sternberg cell is inconsistent or heterogeneous. So when we say it's a B cell origin, what we expect the cells to be positive for? We expect it to be positive for CD20, PAX5, B cell transcription factors like OCT2, BOB1. But despite being a B cell lymphoma, a B cell or not a B cell lymphoma, B cell origin, these expression of these markers are inconsistent or heterogeneous. That will be more clear when I start showing you the slides of these individual cases. So because of the morphology of this Hodgkin lymphoma, that is, these malignant cells are fewly scattered in a reactive background. So because of this, initially it was thought to be some sort of autoimmune disease, and hence it was termed as a Hodgkin disease. But later on, it was found that it is actually responding, this lymph nodes are actually responding to chemotherapeutic agents. And when clonality was done, it was found that the Reed-Sternberg cell or the so-called Hodgkin cells are clonal in nature and was found to be of origin of the germinal center B cell. So hence itself, the term of Hodgkin disease was renamed as Hodgkin lymphoma. Now, we know that Hodgkin lymphoma is associated with EBV, but not all the subtypes, and it is not mandatory. So hence itself, it is some of the subtypes are actually negative for EBV. So hence itself, EBV is thought to be a cofactor and not not one of the etiological factor of a Hodgkin lymphoma. Now, coming on to the clinical feature of Hodgkin lymphoma, it's always good to know how any disease is clinically going to present. The age group is that it can occur either in children or in elderly, except in nodular sclerosis, which is very rare in elderly, usually seen in young adults or adolescents. And the patient presents with a lymphadenopathy. It can be either isolated lymph node like a cervical lymph node or an axillary lymph node isolated, or a generalized lymphadenopathy. Involving the mediastinal, axillary, para-aortic nodes. Non-axial node involvement is quite rare. Usually the classic Hodgkin lymphoma, patients presents with these symptoms. That is fever, loss of weight, night sweats. I would like to spend some time on this slide, extranodal involvement in Hodgkin lymphoma. So it is very, very, very rare, Hodgkin lymphoma with it primarily presenting in an extranodal site. Okay, and most common extranodal organs that is involved is spleen, liver, or bone marrow. And that too, they are involved in a stage 4 Hodgkin disease. So usually when we have a bone marrow involvement, the patient would be having concomitant generalized lymphadenopathy. So before making a diagnosis of a primary extranodal Hodgkin lymphoma, or you should always rule out a differential diagnosis. If it is in the GI tract, you should think about it enteropathy associated T-cell lymphoma or a EBV associated DLBCL. If it is a skin cutaneous ALCL or a lymphomatoid papulosis, in case of lung lymphomatoid granulomatosis, which are all mimickers of Hodgkin lymphoma. So recently we had a case where the patient had presented with cytopenia. The bone marrow showed some infiltrate of atypical cells, which was looking like a Hodgkin cell, but the patient did not have any history of lymph nodes. No radiology scan was done. But when because the morphology was like a Hodgkin lymphoma, we pursued and put the IHC of a Hodgkin lymphoma. And then later on, when the clinician was asked to do the PET, the lymph nodes were found out and was diagnosed as a Hodgkin lymphoma. But this was a case where bone marrow was involved, but at the same time, the patient had lymphadenopathy. So most of the time, when we see an extranodal involvement, the patient usually have involvement of other lymph node. It's usually be a stage 4 disease. So primary extranodal involvement of Hodgkin lymphoma is very rare. Now, coming on to classic Hodgkin lymphoma, how are we going to diagnose? So basically, we have to see, it's simple. We have to see two compartments. One is the tumor cells, which are the Hodgkin cells, and one is the background. Now, this Hodgkin cells can be of varied morphology. It can be of typical mononuclear Hodgkin-like cells. It can be a Reed-Sternberg binuclear cells with prominent nucleoli. It can be a lacunar cells, where the lacunae are an fixation artifact. And we are seeing these large cells within the lacunae, which is seen in nodular sclerosis. It can be mummified cells. Sometimes you may not even see, especially in core needle biopsy, all you get is these kind of mummified cells with hyperchromatic nuclei. Yeah, but then which is taking up the marker for Hodgkin cells. Yeah, and then another morphology is that of a popcorn-like cells, which are seen in nodular lymphocyte predominant Hodgkin lymphoma. So these are the different morphological presentations of these main tumor cells. What about the background? If I say that people what happens is that people concentrate too much on the Hodgkin cells that they usually neglect the background. But I would say that the background is as equally important as that of a Hodgkin cells or the malignant cells, and never underestimate the background. The background can be of different types, that it can be polymorphous, that is composed of neutrophils, lymphocytes, histiocytes, plasma cells. It can be lymphocyte-rich background. It can be having a lot of necrosis. And now I would like to spend some time on necrosis. Now, usually what we see is even in high-grade lymphomas, like a Burkitt lymphoma, where the Ki67 is 100%, we hardly find any necrosis. Necrosis is not a very common feature of a lymphoma. One lymphoma where you actually get to see a lot of necrosis is Hodgkin lymphoma. And another scenario where necrosis is seen is when the patient is diagnosed with lymphoma somewhere and that patient was given some steroid therapy. And that is when we get to see necrosis in a lymphoma. So a necrosis in lymphoma, one of the differentials that should come into your mind should be a classic Hodgkin lymphoma or a patient having given some steroid treatment. Now, sclerosis, sometimes in nodular sclerosis, especially in mediastina, we never get to see a excision biopsy from a mediastinum. All we get is a core biopsy. So multiple cores was taken, multiple time attempted, but all we get is sclerosis, because most common subtype of Hodgkin lymphoma in a mediastinum is a nodular sclerosis. So the sclerotic background, so we should look very carefully in whether amongst the sclerosis is there any scattered Hodgkin-like cells which will help us to make a diagnosis. So the background is very, very important in Hodgkin lymphoma. Now, coming on to the Hodgkin cells, as I told you, these cells are basically of germinal center B cell type origin, but the lineage expression is heterogeneous or very low expression. So even though it is B cell, what we see is that CD20 is usually not expressed. If expressed, the expression is usually lesser than that of the background lymphoid cells. PAX5, which is also a B cell marker, is dimly expressed. Octobobon, which is a B cell transcription factor, is negative. Now, what about LCA? LCA, which is CD45, is negative. And CD30 is positive, CD15 is positive. So, one way to tell that this Hodgkin lymphoma, Hodgkin cells are abnormal, one is basically by morphology. We see the morphology, we see the atypical cells, we'll suspect a Hodgkin lymphoma. Other is immunohistochemistry. So, even though what is the immunohistochemistry hint that gives us that these cells are abnormal? Even though they are B cells, they do not express CD20 octobobon, unlike an immunoblast, which is going to be a mimicker of a Hodgkin cell in a reactive background. Immunoblast would be positive for LCA, whereas our Hodgkin cells, LCA usually is a marker which comes positive in all the hematopoietic cells, most of the hematopoietic cells, whether it is be lymphoid cells, neutrophils, eosinophils, most of them are LCA positive. So loss of LCA is something which is very abnormal. Okay, so that is something which would favor that the cells are abnormal. Now, CD15, what is CD15? CD15 is the myeloid marker, which is expressed in neutrophils, eosinophils, which is not usually expected to be positive in a B cell. So, expression of CD15 in a Hodgkin cell is definitely making it to be an abnormality. Yeah, and rarely they are found to be expressing some of the T cell markers, CD4, CD3, and very rarely CD3 and CD7. So most common T cell marker which I have seen the Hodgkin cells should be expressing is CD4. So this is on the immunohistochemistry of the Hodgkin cells. So when we see the slides, overall what I've said would be you will be more clear when you see the individual cases. Now we shall go to individual subtypes, and I will show you the cases of each subtype. So the first subtype that we are going to see is a nodular sclerosis. As I told before, it is usually rare in elderly. The age group usually is an adolescent or young adult. And the presentation is usually the supradiaphragmatic lymph node. And most commonly, mediastinum is often involved, and EBV is usually negative. So, shall we discuss the case one? This is a case of a 25-year-old female who was evaluated for left cervical lymph node. The patient did not have any B symptoms. Okay, the CBC was within normal limit. Yeah, CBC, whenever a lymphoma case is you're diagnosing, you should always look at the peripheral blood, the radiology. Yeah, the CBC showing a cytopenia, maybe a subtle clue that maybe a bone marrow is involved with the tumor cells. So here the CBC is perfectly normal. The PET showed high uptake generalized lymphadenopathy, conglomerate nodal mass above the diaphragm. So SUV was 20.3. The size of the node, largest node was 5.1. And the radiological impression was that it was an active lymphomatous disease. There was no uptake in spleen, liver, or marrow in radiology. The LDH was 3.5. Okay, now I'll show you the slide. So what do we see? This is a scanner view 4x, but I would love to have a 2x when I take a lymphoma class because that is when we get to see the entire lymph node. Okay, but as of now, we will see with the scanner view. So in the scanner view, what we see, this is a lymph node. Yeah, everybody is convinced that this is a lymph node, right? We see some lymphoid cells, we see the capsule. We'll start from the outside of the lymph node. How is the capsule? The capsule, is it thickened? Yeah, is everyone convinced that this capsule is thickened? It appears to be thickened, right? So in one of the feature of Hodgkin lymphoma is a thickened capsule. So when do you get a thick capsule? A thick capsule usually when there is something is chronic involvement of a lymph node. In a low-grade lymphoma, in a Hodgkin lymphoma, or a chronic disease which is involving, even non-neoplastic disease which is involving the lymph node, tend to produce a thick capsule. So when you get a thin capsule, something which is proliferating rapidly, that the lymph node doesn't have time to get a reaction, is when you get a thin capsule, like in case of a Burkitt lymphoma, where the rapidly progressing cells will make the capsule to be very thin. So as of now, we are seeing thick capsule here, right? And now what do we see here? This capsule is going in like a fibrous septa. Yeah. and there is some big nodules out here. Remember, this is still the scanner view. We have not gone into hyper. So this capsule is going into fibrous septa, and we are getting so many nodules. Clear? Is the nodules visible for everyone? Large nodules separated by fibrous septa. What are these cells? Something standing out. These small cells standing out within these nodules. Yeah, is very clearly standing out. Now the background, some lymphoid, at least in this power, and we are seeing some large cells standing out. So if I say time that you have to spend the most is in 4x. In any lymphoma case, spend 90% of your time in 4x and then come to 10x or 40x just to confirm your diagnosis, what you have seen in 4x. Okay, 4x or the scanner view is the most important the magnification in for a diagnosis of a lymphoma. So kind of, I've already made this diagnosis in my low power 4x. I've seen thickened capsule separating the thing into the fibrous septa, separating it into large nodules. Then I'm seeing this large scattered cells here, which is in the background of some sort of reactive lymphoid background. I've already made my diagnosis. I'm going to just confirm it in my high power. So what do I see? This is my 10x. Again, the large cells are very, very conspicuous here. Some sort of lacunae, the lacunar cells, if you remember the lacunar cells that I've shown you in the picture, this is exactly similar to those cells. So we can see this tumor cells with the prominent nucleoli. What about this background? This background, the very small lymphoid cells, reactive lymphoid cells here. The background, then the sheets of these large cells. Shall we go a little bit more onto the higher power, 40x? Okay, so these were the large cells that we were seeing, the lacunar cells. This is the 40x. Yeah, then we are seeing these eosinophils here, the background. Then the small cells are lymphoid cells, small lymphoid cells. The background is reactive. I don't see any ATP in the background. I see this large cells scattered here, lacunar cells. My diagnosis in morphology is a nodular sclerosis, Hodgkin lymphoma as of now. What about this area? One second. Okay, I'll show you the immunohistochemistry now. So what are we going to expect in the immunohistochemistry? CD20. So one thing I wanted to tell is that whenever we diagnose Hodgkin lymphoma in a low power, in a HE section, it should be like the Hodgkin cell should be staring at you. It should not be a situation where we are going and hunting for the Hodgkin cells. So my guide, Dr. Gujral, when I was doing my DM in Tata, would say that if you are going and hunting for the Hodgkin cells, most probably it is not Hodgkin lymphoma. So in low power, the Hodgkin cell should actually stare back at you, and it should be very easy for you to diagnose the Hodgkin cells. Okay, whenever we are desperately trying to look and find the Hodgkin cells, it is unlikely that it's going to be a Hodgkin lymphoma. Now this is the CD20. So what do we see in the CD20? CD20 is very little, right? Very scarce. Compare, you just see a residual some CD20. We don't see any lymphoid follicle. We don't see any normal lymphoid follicle out here. That is another feature of Hodgkin lymphoma. Whenever Hodgkin lymphoma is involving a node, we don't get a residual lymphoid follicle unless and until it is a partial nodal involvement. If the rest of the node is reactive and the area where the Hodgkin lymphoma is involved, we never usually get a reactive lymphoid follicle. Okay, so this is the B cells. But I'm not happy just by looking and seeing that there are some B cells. I want to see what is the expression. This is CD20. I want to see what is the expression of CD20 in the large cells. Whether large cells are CD20 positive or negative. Okay, so shall we go and see?
Negative. Negative.
Yeah. Can you see these large cells? Yeah. So always you should have in lymphoma, another thing is that you should, as important as the positive staining is the negative staining. So your counter stain should be very bright and crisp so that you are able to understand the individual cells and see that these large cells are negative. I'll show you more. So the CD20 is definitely negative in the large cells. Yeah, it's negative in the large cells. We shall go and see the CD3. CD3 definitely more than that of the CD20. So for nodules are very clear in this CD3 IHC. Okay. And the feature of classic Hodgkin lymphoma is background is T cell rich. Now, when I come to NLPHL, you'll understand the difference of NLPHL from that of a classic Hodgkin lymphoma. Here, we hardly saw a little bit of B cells, but then the background is T, predominant T. So, classic Hodgkin lymphoma, the background is T cell rich. Yeah. And we'll see again the large cells here. So the large cells are actually negative. This is the surrounding T cells which have taken up the CD3. We are seeing the scattered large cells here within the background of CD3. Now coming on to CD30. Yes, CD30 has beautifully highlighted the large cells. And it's kind of in a little bit in sheets, maybe not sheets, clusters. And what is the pattern of CD30 staining? You see here, there is a membrane with a Golgi dot-like staining, Golgi-type staining. This is very, you have to see that Golgi dot-like staining, which is very characteristic of a Hodgkin lymphoma. So CD30, we are seeing this large cells are positive for CD30, showing a membranous as well as a dot-like Golgi staining. So the cells are positive for CD30, negative for CD20. Okay, I will show you the Golgi-like staining a little bit more in hyper. So all of these cases, all of this I was showing you in scanner view. So I'm emphasizing that scanner view is the most important magnification for a diagnosis of lymphoma. This is a Golgi-like staining out here. Beautiful. Now CD15. Yes. So what are the normal cells that take up CD15? As I told, neutrophils can take up. Okay. So we have a nice control of small neutrophils, which is very neutrophils or myeloid cells, which is positive for CD15 here. Small. The size is very small. And what about the large cells? The cells which we were thinking as the Hodgkin cells. They're positive for CD15. Very nice, brightly positive. So this cell is showing aberrant CD15 positivity. CD30 positive. Morphology, I've already diagnosed it as nodular sclerosis, and I've just confirmed it with my immunohistochemistry, CD20 negative, but 15 positivity, I don't have to do anything else. Ideally, what we commonly do is a PAX5. So there was a period here where we were struggling to standardize our PAX5. That is why in this case, I could not show you the PAX5, but then there are a few other cases where I can clearly show you the PAX5. So in these cells, if you do a PAX5, the PAX5 would be very dim compared to the reactive B cells, which in the further cases you will be able to see. So any doubt in this case? Any questions, any queries? So this is another case of nodular sclerosis Hodgkin lymphoma. So here what you see, it is highly sclerotic, right? As I was telling, sometimes this it can be nodular sclerosis variant can be either cellular, where you get a lot of lymphoid cells in the background, or it can be highly sclerotic. So here the majority of the lymph node is sclerotic. If this was if a core biopsy was done from this area and it was a mediastinal mass, then what we will get is only this bands of sclerosis. Yeah. So I took this another case of nodular sclerosis, which is where the sclerosis is very prominent. And we hardly find some vague nodules within the sclerosis. And again, if we look, I'll show you one area where we are going to see the abnormal cells. So this was a place where the Hodgkin cells are not very clear, but then this kind of cells, kind of very atopic looking hyperchromatic cells. Yeah, the mummified looking cells. Yeah, remember I had shown you some mummified cells.
Yes,
Yeah, so these are the mummified looking cells. The background is very reactive, very nice small lymphoid cells here, some histiocytes, some eosinophils maybe. So the background is reactive. There is some kind of these kind of cells, mummified cells, not the classic RS cells or Hodgkin cells. Here, maybe this is one of Hodgkin cell. Yeah. So if you look at the size of the Hodgkin cell, it's drastically different from that of the reactive background. So this is one feature which will help you to diagnose a Hodgkin lymphoma when you are struggling with a T cell lymphoma. In a T cell lymphoma, you don't actually, there is no clear-cut separation between the Hodgkin cells and the reactive background. There'll be different size of cells of no, large, small, intermediate, mixed. Whereas in Hodgkin lymphoma, in the characteristic, you get this large cells standing out in the small reactive background. Okay, and which will be even visible in a low power view. So again, here we because of this the morphologically, I'm seeing this large cells in a reactive background with sclerosis, lot of sclerosis. Yeah, maybe a sclerotic variant of a nodular sclerosis. I put my provisional diagnosis on morphology was that of a Hodgkin lymphoma. So I had put the immunohistostains stains. We'll see CD20. Very few. Yeah, as expected. CD20 is very little. And what about the large cells? We need to see the large cells. Whether CD20 is positive in these large cells. Is it positive? No, it's negative. So these large cells are negative for CD20. So there are cases where you will get CD20 positive Hodgkin cells. But in those cases, most of the time, if you see that the CD20 intensity would be not as strong as his background B cells. It will be a little bit more dimmer. And then when you put other B cell markers like CD79 alpha or OCT, BOB1, they would be usually negative. Okay. So CD20 in this case is negative. What about PAX5? You see these large cells? Okay. So those are our normal B lymphoid cells which has taken very dark PAX5 in the background. And these small cells, there is a faint blush of PAX5. Yeah. So is this weak PAX5 positivity?
weak.
Whereas the surrounding T cells are negative for PAX5. We are having this bright positive PAX5 for reactive B cells, whereas our large Hodgkin-like cells is negative for PAX5. I mean, weak for PAX5. So PAX5 is a very, very nice marker in Hodgkin lymphoma. PAX5, CD15, LCA. So dim PAX5, positive for CD15, absence of LCA. These are markers which will help you to diagnose a Hodgkin lymphoma in difficult cases. CD15 in this case was negative. So will this prevent me from diagnosis Hodgkin lymphoma just because CD15 is negative? No, I had a low PAX5. I mean, dim PAX5. The morphology was very suspicious. Yeah.
Yes.
What about LCA? Will we see this large cell? It's actually negative for LCA. This LCA is positive for background cell, but these large cells are negative for LCA. Now I'm quite comfortable. PAX5 is dim, absence of LCA, and I'll show you the CD30, CD cells, CD30 positivity. So this is a nodular sclerosis variant of Hodgkin lymphoma where the sclerosis is very prominent. Any doubts in this case?
No, ma'am.
No, ma'am. No.
Okay. Now we shall go to the next case, next variant, which is mixed cellularity. So mixed cellularity can be seen, unlike in nodular sclerosis, can be seen in pediatric as well as in elderly people. Most often it is presenting with the nodes below the diaphragm, but both sides of the diaphragm also it can happen. Frequently, they are present in the stage 3 or 4 at the time of presentation and associated with these symptoms. Now, this is one feature we should always be very alert about. Background, as I told that never underestimate the background of a Hodgkin lymphoma. So whenever the background lymphocytes can show some amount of nuclear pleomorphism, some amount of atypia. But when the background atypia of the lymphoid cells is very frank, you should always think about a T cell lymphoma, which is very common mimicker of a Hodgkin lymphoma. Now, mixed cellularity is frequently associated with EBV. So when we do an EBV, LMB, IHC, which is also one helpful marker where we are struggling whether it's Hodgkin lymphoma or not, but we are not able to standardize it in our lab as of now. So whenever EBV is LMP is positive, that is another feature which will help you to diagnose a Hodgkin lymphoma. So coming to case 2, this is a 68-year-old female who presented with axillary lymph node and had B symptoms. The PET showed generalized lymphadenopathy, axillary, paratracheal, mediastinal. The lymph node was 2. The SUV was 9.7 around, and the radiology diagnosis was suspicious for lymphomatous disease. So we'll see the slide. So starting from the capsule. What do you think about the capsule? Yeah, I'll show you a little bit more of capsule. This capsule is thickened. Yeah, thickened capsule. Here we are seeing very pink node, right? Pink. Why is this node pink? Can anyone tell why the node appears very pink here? Because of what cell?
Hello, PGs.
Histiocytes. Yeah. Because of a lot of histiocytes, the node has started appearing very pink. Can you see these cells? Very dark cells, which is projecting out here in this scanner view?
Yes, ma'am.
Yeah, this one.
Yes.
This one. This one. Yeah, I'll show you in hypogram. This is 10x. These cells, mummified looking cells. This one. This. Here. The background, maybe some myeloid cells are there, which is eosinophils, I guess, some eosinophils. Very nice eosinophils, no? Whenever you see eosinophils, very happy. Most probably it's going to be Hodgkin lymphoma. So what are the other conditions where you get eosinophils in a lymph node? Anyone? Eosinophils in a lymph node. What are the differentials that we should think about? These are RS cells. Very nice, beautiful RS cells, Hodgkin cells.
Hello, Abhijit, why don't you answer this? Conditions with eosinophils in a lymph node.
No takers? Okay, so a T cell lymphoma can have eosinophils in a lymph node. Okay, background would be polymorphous. Then myeloid sarcoma, Langerhans cell histiocytosis. Yeah, even in Kimura's disease. So many conditions where we get eosinophils in a lymph node. Okay, this milieu is very characteristic of Hodgkin, the reactive milieu of neutrophils, eosinophils, the small lymphocytes. And then we are seeing this large atypical cells in this background. And there is drastic difference in the size of this large atypical cells compared to the reactive background. They're just very staring and blaring at you. The size difference, can you see the size difference? Yeah. So there, I'll show you a case where there is a mimicker of Hodgkin T cell, where you don't get this abrupt large lymphoid cells in this background. So this drastic difference in the size, this reactive milieu, this scattered large cells, I've already diagnosed it as a classic Hodgkin lymphoma. I just want to confirm it with my IHC. What is this? What is this that you see here? This. What is this?
Histiocytes.
Histiocytes? I'll show you in hyper. Again, what is this? Apoptotic debris and necrosis. Yeah. So remember when I told that necrosis, lymphomas, which is associated with the necrosis, is classic Hodgkin lymphoma. And usually around this necrosis is where you get a lot of Hodgkin cells, clustering of Hodgkin cells. So if you are finding it difficult to search for Hodgkin cells, always look around necrosis. Where you here. Convinced? CD30 positive, very nice positivity. With a very nice Golgi-like stain, dot-like Golgi stain.
Yes.
Golgi stain, membrane, beautiful CD30 positivity. What about CD PAX5? Yeah, here the PAX5 is much more better than our previous PAX5. You see this very dark lymphoid cells reactive here, strong PAX5, and compared
Yes.
to lymphoid cells, these Hodgkin-like cells are showing weaker expression of PAX5. Yeah, this is a strong PAX5, this is a weak PAX5. So weak PAX5 abnormal. So again, favoring Hodgkin lymphoma. What about LCA? Sometimes LCA can be very difficult to interpret because of this background cells. But I will show you cases where the LCA is positive when we come to NLPHL. So it will be more clear to you when I say that the LCA here is negative and not positive. Because of this background cell is very difficult, but when you get a positive LCA, once you see a case of positive LCA, then you will understand the difference between this LCA and when the large cells are positive for LCA. This LCA is negative because it's not standing out from this background T cell. If it was positive, it should have shown staining like this, very dark brown staining. So this LCA is negative. Beautifully positive CD15. Yeah. And this is showing a Golgi-like staining. I'm so happy with this stain. CD15 positivity. So this is the yes. It's clear. It's not clear. Okay. So again, so what is the diagnosis here? CD3. I told you classic Hodgkin lymphoma. The background is T cell rich. I'm constantly emphasizing on this because when we come to NLPHL, there the background is quite different. Here the background is T cell rich. So that was about mixed cellularity Hodgkin lymphoma. Now coming on to the next case. Any questions on that case? Any query?
No, ma'am.
So that was mixed cellularity. Now coming on to the case 3. So lymphocyte-rich classic Hodgkin lymphoma. It's comparatively rarer compared to the other subtypes. It's 5% of the classic Hodgkin lymphoma. Usually a localized disease without any bulky nodes, no B symptoms, similar to an NLPHL. NLPHL is also usually presenting like a localized node, yeah, without B symptoms most of the time. So, and the microscopy also, it is differential comes with the NLPHL. It's nodular, like an NLPHL, rarely diffuse, and prognosis is slightly better than that of a classic Hodgkin lymphoma and more like an NLPHL. So this was a case of a 14-year-old male who presented with the right cervical lymph node since 2 months. There was no B symptoms, just an isolated cervical lymph node clinically. On PET, there was an intraparotid node in addition to the right cervical lymph node. The SUV was low, 6.6. The size was 3 centimeter. The radiology diagnosis was likely lymphomatous disease and no abnormal uptake anywhere in the body. So this is what we had got. Again, the capsule is thickened. Yeah, very nice thick capsule here. So we have a node. Can you appreciate the vague nodular pattern here? Vague nodular pattern. Nodules.
Yes, ma'am.
Yeah.
Yes.
Are there some large cells here? These cells standing out in scanner view?
Yes.
Yes, ma'am.
Yeah. Again, on higher part, something prominent nucleoli, large cells, and the size is very high compared to the background small cells. The background cell doesn't show any atypia, very nice reactive lymphoid cells. The size of the Hodgkin cells is quite increased compared to that of the background cells. We have the prominent nucleoli. So clinic, we will think about Hodgkin lymphoma here. Nodules, okay, fine. But could it be NLPHL? Could it be lymphocyte predominant Hodgkin lymphoma? Because I hardly see any histiocytes, I hardly see any plasma cells, eosinophils or neutrophils. Its background is quite lymphocyte-rich Hodgkin lymphoma. Lymphocyte-rich. So my differential could be an NLPHL or a lymphocyte-rich classic Hodgkin lymphoma. So how are we going to differentiate? So classic Hodgkin lymphoma, as I told, even though it is a B cell, germinal B cells, the expression of B cell markers are quite downregulated. Whereas NLPHL is having a robust B cell expression, lineage expression. That will be strong for CD20. It will be strong for PAX5, OCT2, BOB1. Yeah, I'll be that will be more clear when I show you the slides and cases of NLPHL. Okay. So this is my differential in morphology, a lymphocyte-rich Hodgkin lymphoma versus an NLPHL. But I'm not seeing any popcorn-like cells, which is characteristically told in a NLPHL. Most of the cells are like these Hodgkin-like cells, the RS-like cells. Okay, we are getting this RS like Reed-Sternberg binucleate cells. So we'll see the immunohistochemistry. So this IHC, and it's not very crisp. The background is not very crisp. So always when you have an IHC in lymphoma cases, always try to make the background negative stained lymphoid cells to look very crisp, so that we'll be able to identify what are the cells that have actually taken up CD30. Is just a non-specific blotch-like staining, or actually the RS-like cells have taken up. So this was it's not a very nice IHC, but then still not very clear. It's a thick section. A lot of the section is appearing to be very thick, but then still I feel that the CD30 is positive in this dark cells. And there is some Golgi-like staining. Okay, positive CD30. For background, we like to see the background. We are told that it was lymphoid cell rich. So how was the CD20? CD20, we are seeing nodules. No? And serpiginous nodules, connected nodules, single nodules. And what? And CD20, you should actually look at those big cells, whether those big cells are positive for CD20 or not. And what do you think? CD20 positivity here. There is a negative cell surrounding the CD20 positive cells, right? Rosetting. And these large cells are positive. Again, Golgi-like stain, very nice positivity. Background is this is a lymphoid B lymphoid follicle. Yeah. So favoring more towards the NLPHL. I'll show you a case of NLPHL later on. And we are having some large cells scattered outside the nodules also. I'll show you. Here. The size of this small cell and this cell, you can actually see the nucleus inside, no? Blue area inside. This is very quite small. This is quite big. And this staining is in fact brighter than that of the background cells, no? Quite bright CD20. CD15. So this was a case where we were struggling between an NLPHL and a lymphocyte-rich Hodgkin lymphoma. Just because, why we struggling? Because the CD15 here, we felt that some of the cells were positive for CD15. Now, CD15 is not something that you expect to be positive in a NLPHL. So, positive CD15 closes the story. There is no differential of NLPHL. It is classic Hodgkin lymphoma. But see here, we were not sure whether these cells are CD15 positive here. So, lymphocyte-rich Hodgkin lymphoma, even though it is a subtype of classic Hodgkin lymphoma, it's said to express these B cell markers like CD20, OCT2, BOB1 in WHO. And here the CD15 looked like it's positive, but the morphology and rest of the IHC was that of an NLPHL, where we are seeing nodules and these large cells within the nodules. CD20 markers are positive. We try put rest of the CD20 markers. That's OCT2, BOB1. Yeah, OCT2, BOB1 are the B cell transcription factors. You see these large cells? Yeah, beautifully positive for OCT2. This is OCT2. Now again, CD15 positive, but then B cell marker CD20 is bright, OCT2 is positive. What about BOB1? BOB1, beautifully, strongly positive. In fact, more positive than the rest of the background B cells. Yeah, OCT2 BOB1 brightly positive. So what should we call this? Should we call this as a lymphocyte-rich Hodgkin lymphoma? Should we call this as a NLPHL? CD15 is positive, but B cell markers also strongly positive. We discussed with the clinician. Clinician was like, this is the T cells. I mean, CD3. You see the beautiful rosetting of the CD3 around these large cells? We didn't have PD1. NLPHL classically tells that there is a CD3, PD1 positive CD3 rosetting around the T cells. But then there's this rosetting of T cells. This is CD3. The background, if you see, is T cell rich. Yeah. This background is here T cell rich, but this nodules, the negative stain, is what full of B cells. There's a B cell nodule, okay, and we are having this large cells scattered within the nodule, which is CD20 bright, which is showing CD3 rosetting, but CD15 is also positive. So is it NLPHL or is it lymphocyte-rich Hodgkin lymphoma? Lymphocyte-rich Hodgkin lymphoma is also a close differential. So as I told, we were discussing with the clinician. Clinician was telling this is a child, most probably it's going to be a classic Hodgkin lymphoma, but not very convincing for us. So what we ended up giving it as a differential. So most probably the differential considered as our NLPHL and lymphocyte-rich Hodgkin lymphoma, favoring an NLPHL. Yeah, this case was sent to Dr. Borges in COP, where they did. What are the other markers that will help you to solve this mystery? One is EBA. If these large cells are positive for EBA, the EBV associated, NLPHL is not EBV associated. EBA, it closes the story, it is going to be a classic Hodgkin lymphoma. Secondly, if you can see the PD1 rosetting of these T cells around, yeah, which will favor an NLPHL. Yeah, Dr. Borges reported, did all these markers. For the EBA was negative. There was rosetting of PD1 around the L and H cells. CD15, according to them, was negative. Yeah, so we were also not very convinced whether CD15 was positive or negative. So for them, the CD15 was negative, and finally it was diagnosed as NLPHL. So this was a case where we have this difficulty in the practical difficulties that we face while diagnosing a Hodgkin lymphoma. So now coming on to the next case. So it's a lymphocyte depleted Hodgkin lymphoma is very rare, less than 2% of the cases. And usually there is association with HIV infection. It is similar to, background is similar to a mixed cellularity. There would be more of histiocytes, less of lymphocytes. And fibrosis and necrosis is more common in lymphocyte depleted. In such cases where the background is very depleted and you see the syncytial sheets of this Hodgkin cell, the differential that comes in a lymphocyte depleted Hodgkin lymphoma is a B cell lymphoma, like a DLBCL or an ALCL or a syncytial nodular sclerosis Hodgkin lymphoma. I don't have a case of lymphocyte depleted Hodgkin lymphoma to show you. I'm sorry. Then we'll go on to the next case. That is nodular lymphocyte predominant Hodgkin. Now, NLPHL is a very, very distinct entity. Even though it is put under Hodgkin lymphoma, I think most probably in future it is going to be removed from under the umbrella of Hodgkin lymphoma and put into a non-Hodgkin lymphoma. Now, why is it different? How does it make it? What is so special about NLPHL? So it accounts for 10% as of now, it is under Hodgkin lymphoma, and it accounts for 10% of all Hodgkin lymphoma. There's a wide age group. Median age group is around 30 to 40 years. Usually present as localized disease. Again, this presentation is very important. NLPHL usually presents as localized disease. Okay, you will have an isolated cervical lymph node or axillary lymph node involving the peripheral nodes. Okay, if the history is very extensive, is that of extensive disease with multiple lymph nodes, marrow involvement, most probably it may not be an NLPHL. My mentor, Dr. Gujral, would always say that if I get an NLP, if you get an NLPHL with a stage 4 disease, like a bone marrow involved, then most probably it's going to be a T histiocytic rich B cell lymphoma. Yeah, and it is better to diagnose it as a T histiocytic rich B cell lymphoma. And I feel, in fact, it might be true to some extent because NLPHL stage 4, which is involving the marrow, and a T histiocytic rich B cell lymphoma, this may be a little bit more too much for the PGs. It's actually treated in a similar way. They're given as archo-based regimen. It is just the stage 1 NLPHL. We have the option of observing the patient or just giving a radiotherapy alone. Yeah, the highest stage NLPHL are treated with rituximab-based regimen of R-CHOP. Now, NLPHL usually doesn't have any B symptoms. It is an indolent disease with an excellent survival, okay, with a localized disease. So these are the things that you have to keep in mind. So clinical features are very important whenever you diagnose a lymphoma. Now, as I told before, NLPHL, even though now it is under the umbrella of Hodgkin lymphoma, most probably in future is going to be put under B-cell lymphoma. So the query, the big million-dollar question is that whether NLPHL should we call it as a nodular lymphocyte predominant B-cell lymphoma? So recently, whenever the recent update on lymphomas, when it came out this time, it was quite different. We had two groups coming up. One is the WHO, where Dr. Gujral is one of the editors of the WHO, where they proposed that okay, NLPHL is still under Hodgkin lymphoma. It is, but it could be in future become a B cell, put under a nodular lymphocyte predominant B cell lymphoma. So on the way to B cell lymphoma, but as of now, we'll retain it for the Hodgkin lymphoma for the purpose of clinical trials. Whereas this ICC, that is the International Consensus of Classification of Mature Lymphoid Neoplasm, where Elaine Jaffe is one of the members, they propose that no, Hodgkin, it is not right to call NLPHL as a Hodgkin lymphoma because it's just the morphology that is mimicking that of a Hodgkin lymphoma. You have the scattered large cells in the reactive background, but the immunoexpression, everything is quite different. It has robust B cell markers. All the B cell markers, CD20, PAX5, OP2, are very quite bright. There is no CD15. It's not associated with EBV. There's nothing to call it like a Hodgkin lymphoma. So the term NLPHL is obsolete. It should be replaced by nodular lymphocyte B cell lymphoma. Okay, and it is seen to have a close relationship with B-histiocytic rich large B cell lymphoma. Now, diagnosing NLPHL does not complete your diagnosis. We have different variants of NLPHL. That it is important to tell what is the variant of NLPHL. Now, why is it important to diagnose a variant of NLPHL? Just giving a diagnosis of NLPHL won't suffice. Because as I told, whenever different subtypes is made, it is because either it has impact on diagnosis or impact on prognosis or impact on prognosis. So there is WHO says that there is different patterns, pattern A, B, C, D, E, F. Okay, and this A to F pattern can be further put in two grades, grade 1 and grade 2. If you see this green box, blue box, this is grade 1, pattern A and B. That is the majority of NLPHL where we come across is going to be in this grade 1. The classic pattern of NLPHL, where again the background is this brown is the B cells. So background is B cell nodules you get. You have some T cells in the background, then the large cells are within the B cell nodule. So if you remember the classic Hodgkin lymphoma, the background was T cell rich. Okay, we had hardly scattered B cells, it doesn't form any nodules here and there. But here in NLPHL, we have B cell rich background nodules here. Yeah? So that is why I told that I always keep on telling this. See, the background is T cell, T cell. Okay, here in pattern B, again, we have this nodule. Some of these nodules are merging into a serpiginous pattern. So this pattern is very nice, clear grade 1 NLPHL. It is managed similar way to an, as I told before, stage 1 and stage 4, what I've been mentioning. Whereas what about the grade 2 of NLPHL, where the background starts becoming T cell rich? Okay, just like a Hodgkin lymphoma, in the background here, if you see the white is a T cell, B cell nodules are very, very small. Here the nodules are background, everything is T cell. Here you have no nodules, diffuse pattern, and this is like a T histiocytic pattern, pattern E. Okay, here the background, this is a E and F are the diffuse pattern. Here the difference is that here the background is B and we have the T cell in the serpiginous pattern. But if you do a CD21 or FDC meshwork, you will not find any nodules in this pattern F. Both of these are diffuse patterns. Okay, so this grade 2 pattern, anything other than grade A and B, that is classic NLPHL with B lymphodnodule, anything other than that is found to have a poorer prognosis. So the ICC proposed that the patients with grade 2 histology may warrant a treatment for DLBCL. But the caveat is that clinical features should play a role in treatment. Okay, so it is our duty to tell what is the grade and whether the clinician should, it's up to the clinician to think whether they should treat it aggressively. So where they are in the borderline and we are telling that it's a grade 2, it will give them a push for a more aggressive management of NLPHL. Yeah, so that is why it is important not just to diagnose NLPHL, but we need to say what is the pattern, at least what is the grade that the NLPHL comes in. Okay, I told that T is histiocytic rich B cell lymphoma stage for NLPHL. Before diagnosing it, most probably it is going to be something else, or probably a T is histiocytic rich B cell lymphoma. And it's very difficult to diagnose, differentiate between an NLPHL and T is histiocytic rich B cell lymphoma. Okay, this is the theory part. It's very black and white in theory, but when you come into the practical aspect, sometimes we will be really struggling. So in that cases, if it is a stage 4, maybe it is better to call it as a T histiocytic rich B cell lymphoma. How do you differentiate between an NLPHL and T histiocytic rich B cell lymphoma? So I told that NLPHL, if it is a classic pattern, it's usually the difficulty comes in pattern E, where the background is T cell rich, it's diffuse, there is no lymphoid follicle. Okay, but still we will see in NLPHL residual B cell, small B cells would be there in background. T histiocytic rich lymphoma, hardly any B cell, very few B cells. Okay, then we have the classic LP cells. There that in histiocytic B cell lymphoma, the malignant cells are of variable histology. Okay, the FDC measure CD21, 23 would be present in NLPHL. Okay, whereas T histiocytic, that is in rest of the patterns, in pattern E, not in pattern E. And T cell rosetting is an NLP, it's characteristic of NLPHL, PD1 positive T cell rosetting, which is not found in T histiocytic rich B cell lymphoma. And NLPHL usually stage 1 clinically. Sorry. Any questions? Okay, usually stage 1, and whereas T histiocytic rich B cell lymphoma is aggressive. Now that still debates are going on whether NLPHL and T histiocytic rich B cell lymphoma is the spectrum of the same disease, where NLPHL is in the lower end, the indolent end of the spectrum, and T histiocytic rich B cell lymphoma is in the other end of the spectrum, or whether it is a primary disease or it's just that NLPHL was there and it has progressed into T. So we have seen so many cases where initially it was NLPHL, and when the disease progressed, it had a morphology of a T histiocytic rich B cell lymphoma. Okay, and it was even gene mutations. When we studied, it's found that both the tumors had similar gene mutations. Okay, yeah. So shall we come on to the case? So I've been talking so much about NLPHL. Hopefully, so what is that we are going to see in NLPHL? We'll get nodules, and how the nodules are going to be of B cells, not the T cells, and we'll have scattered cells within nodules, outside nodules. The scatters are going to be CD20. All the B cell markers are going to be bright, robustly positive. Okay, this is what we are going to expect in an NLPHL. Now, this is a case of an NLPHL, 64-year-old male who presented with left neck swelling, which was gradually increasing in 5 years. Okay, very indolent course. Single neck swelling. Wow, the presentation is very classic. Okay, the PET showed avid left intraparotid left cervical node, SUV 8.9. The largest node is 4 centimeter, and they had a left axillary lymph node. No other lymph nodes anywhere. Radiologically told that it's a lymphomatous disease. So this is the lymph node. Let me see here. Are you able to appreciate the nodules? Vague nodules.
It
always,
is.
if you
Yes.
are if you're having any doubt, you always dim your light. That will be helping you to identify these nodules more clearly. There are these nodules, vague nodules. There are some cells, kind of something out here, which is quite larger than the rest of the cells. Show you in a little bit more hyper. These cells here are some of them quite high, some of them looking like RS cells, some of them like Hodgkin cells. Yeah, background is reactive, small B reactive cells. Okay. I wanted to show you some popcorn-like cells, as I described. Maybe this is some sort of popcorn. If you can stretch your imagination. Okay. So anyway, there is this large mononuclear cells, binucleate cells, okay, with prominent nucleoli in a reactive background. We were seeing nodules. Yeah, morphologically, single nodal presentation. Even classic Hodgkin lymphoma can present as a single node. So Hodgkin lymphoma as of now, morphological diagnosis. in a reactive background. How was the background? The background was not mixed. It was lymphocyte rich. Yeah. Don't see any neutrophils, don't see any eosinophils, or not very pink. That means not much histiocytes. It is blue. Okay, lymphocyte rich background with scattered large cells. CD30. So NLPHL usually CD30 negative. It can have CD30 positivity also. CD30 negative. Yeah, this is CD30 negative.
Yes.
What about CD20? CD20 positive,
Positive.
quite bright positive, and not just positive in CD20. What is that? Is it within the B cell nodules? The cells?
Yes.
Cells are within this large B cell nodule, right? So
Yes.
background, you should never ignore the background. Okay, it is a large B cell nodule. You have seen the large cells within this nodules. Okay, but what is more important? Is it
Background.
surrounded by B cells? Is it surrounded by B cells? No. Yeah, there's some cells which is negative for B. Most probably T. Yeah,
T cell.
surrounding these large cells with bright CD20. Beautiful. Okay, we'll see now CD3. Okay, this is a large cell. The counter strain is not very crisp here, but I think you're convinced that this is a large cell. Should I show you something else?
No,
Maybe.
ma'am.
Okay, let me see. Okay, these cells, the counter strain is not very crisp, but this one, I think all of you can make out this cell.
Large cell.
Yes,
Ah,
ma'am.
so this is CD3. So it is surrounding this large cells. But ideally, we need PD1, and we should show that these PD1 positive T cells are rosetting around these cells. We don't have PD1 here, but then we are quite happy with that CD20, which is showing a negative cells around the large cells. Yeah, so CD3 is around these large cells, which has taken up CD20. Octo Bob1. So CD20 is very bright. Octo is very bright. This is Octo. Beautiful Octo. Positive, very bright Octo. Bob1. You see this large cells, just very bright Bob1 compared to the background B cells. Yeah. So B cell markers are robustly positive. The cells are large, scattered within the B cell nodules. Okay, CD15 negative. So what is the diagnosis here? CD15 is negative. So these are the cells which is negative for CD15. This is. So it is a lymphocyte predominant Hodgkin lymphoma. What is the pattern? So if there's a diagnosis of NLPHL, will it suffice? So how was the CD? No.
Not
I think grade 1. Yeah. So we are seeing some nodules. Maybe some of the has a subpedial nodule. Fine. But if it is pattern A, it is grade 1. Not a decent background. Okay, I we can stop here with NLPHL. Yeah, then mimickers, it's just 1 or 2 slides. So the common mimickers that we have encountered here, commonly diagnosed as Hodgkin lymphoma, which has come here is one is ALCL, anaplastic large cell lymphoma. And why does it come as a mimicker? Because CD4 is one of the aberrant markers which is usually seen in Hodgkin lymphoma, which comes in syncytial sheets. Whenever the Hodgkin lymphoma in syncytial sheets, some CD4 positivity. Okay, and then this T cell lymphoma is one of the common misdiagnoses that have come here as a Hodgkin lymphoma. Okay, then other NLPHL, the mimicker is a reactive lymph node. The immunoblast of a reactive lymph node may be misdiagnosed as a nodular lymphocyte predominant Hodgkin lymphoma. So there are so many mimickers. Yeah, so any questions so far? I think we'll wind up the class now because it's time. Any queries? Any questions? I hope it has been fruitful for all of you. Did you understand something?
Yes.
Yes,
Yeah.
ma'am. Yes, ma'am.
Okay, so I think.
Thank you, Dr. Ann. Thank you.